Hey, welcome all on Zoom and in the room. We have a small group. It's the morning. This is our first ever morning global mental health lecture series. But really happy to have you here. And it is not morning for Linnet Ongeri. It is evening. So that is why we are having it in our morning so she can join us. Yeah, really excited to have Linnet here today. I think this topic and the way that Linnet's research and clinical work and policy work all intersect is really exciting. And I think one of the ways that I hear our faculty and researchers talking about wanting to be in the world, that they want to be able to like integrate all these aspects of their practice. And so I think it's just really exciting to have Linnet join us and kind of give us an example of how it works together really beautifully. So I'm going to just start with a land acknowledgement. I wanted to say this morning that in these times of like troubled times, like I feel, and like really challenging times, I feel like the land is always my companion and is even more like a place of solace for me. And in that, I feel tremendously grateful for the care and love that have been that make this land so beautiful and healthy and vibrant because of the care and love that it's received from this Coast Salish people from all the time into this present time and into the future. Like this land is cared for and stewarded by these people, and we are here, you know, as uninvited guests, yeah. I work to belong to this place in as big a way as I can be and to steward it as well as I can in that sense. So thanking the land, the waters, plants, the animals, all the beings, and the people that have loved it so well. I'm gonna actually read Linnet's bio because I was reading it before and I don't usually do this, but I think there's a lot here that I just want to say and have it out in the world for you all to hear. So Dr. Linnet Ongeri is a psychiatrist and a mental health researcher at the Center for Clinical Research, Kenya Medical Research Institute, KEMRI, where she leads the mental health department. With an extensive research portfolio, Dr. Ongeri's work spans various mental health domains with a particular focus on implementation research aimed at integrating mental health services into primary care settings. Her PhD research concentrated on suicide epidemiology in low and middle income countries, a field where she remains deeply committed to. Currently, she leads several projects centered on suicide prevention, reflecting her passion and dedication to addressing this critical issue. Beyond her research contributions, Dr. Ongeri is actively involved in shaping national mental health policy. She served as a member of the Presidential Task Force on Mental Health and participates in multiple technical working groups at the Ministry of Health. Notably, she has played a pivotal role in the Ministry of Health Suicide Prevention Technical Working Group, which developed and launched Kenya's National Suicide Prevention Strategy, now in the implementation phase. And then facilitating the conversation with Dr. Ongeri is our own Dr. Keshet Ronan. And Keshet is an assistant professor at the Department of Global Health and interested in development and evaluation of interventions to promote behavioral health equity in underserved and marginalized populations globally. Her research employs methods from epidemiology, implementation science, and human-centered design. Much of her ongoing work focuses on digital health interventions in the US and in Kenya, and Keshet is passionate about social justice, mentoring, and supporting communities' leadership in developing strategies to improve their own health. So thank you so much, Keshet, for being here this morning and facilitating this conversation. And thank you, Linnet, for being here. Excited to hear the conversation.
Thank you.
Thank you, Linnet. It's such a delight to be in conversation with you today. So as we heard from Leah, you do a lot of things. You're a psychiatrist, you're a researcher, you have a role in policy. And so we want to start the conversation by just hearing, how did you get into this work? Tell us about it again.
All right, thank you. And thank you so much for inviting me to speak today. I really feel honored for that. And how I managed to get into research specifically, I think it was just almost like serendipity. I trained as a psychiatrist, knowing full well that I'm going to practice as a psychiatrist, as a clinician, and I was a lot more, in university, I was a lot more focused around substance use issues. So my goal was to get into a rehab, open a rehab, and just focus on substance use prevention from a clinical perspective. But at some point after finishing my, there's a 1 year we usually do as a registrar once you finished your, it's a specialist recognition year. So at that particular moment of finishing my specialist recognition, this opportunity to do research came about. And I thought to myself, actually, well, I didn't really enjoy researching in med school, in when I was doing my psychiatry specialization. But when I got this opportunity, I thought it was something different, something new. And I've really come to appreciate research because you look at problems from a public health lens. We have very few, there's psychiatrists are few all over the world. So being able to tackle problems from a public health space, looking at things from a public health perspective, touching a lot more lives, I thought it was a lot more fulfilling. And that's what has really kept me in the space of research, and specifically psychiatry or mental health research. But initially, I really did think I would be, a clinician and just do clinical work. And I don't know if your question was bearing towards being a psychiatrist or researcher or a clinician.
Yeah, I think all of it. I mean, I think we'd love to hear like how is it that you came into having all of these different roles within your career?
Okay. So yeah, my role really, when I got the opportunity, there was a position for the first time after a lot of lobbying in Cambridge. There was a position that was created for mental health. Cambridge has been really big on infectious disease. Suddenly things were changing. People are starting to understand that mental health is really at the core of all these health systems. So at that point was a lot of lobbying, and they said we have to have a psychiatrist or a mental health researcher in Cambridge because it's a government parastatal for medical research. And that's how the position was created, and they advertised for the job, and I decided, let me try this. And also there were very few psychiatrists who were interested in research. Again, we are just trained with that shift of doing clinical work. So it's like you have to really, there's a lot more to discover in psychiatry. I feel like it's a bit of a younger science compared to other things. So research would really be the space to be in if I'm going to be in this line of psychiatry, because now I'm in that forefront of figuring out things, discovering new things, and making a difference also from a larger perspective. And then being in research, because all the time when you do research, you're also disseminating the work. We do a lot of policy briefs based on the findings of our research. That means we have to interact a lot more with people in the policy space, so the Ministry of Health. So even before we start the research, when we are conceptualizing the study, we end up having a lot of discussions with the teams at the Ministry of Health, the director of psychiatry, the director of mental health at the Ministry of Health. So it means I work extremely closely with that team. And then anytime that director at the Ministry of Health needs data on mental health, my team and I are the ones who actually go online, work through all the data that is out there, and give them the information that they need so that they can write that in their policy documents. So in that way, I've managed to we work almost hand in hand. And also the fact that Cambridge is a government parastatal, it means we are sort of part of the government system. So getting involved into the policy space became almost a seamless collaboration. because of the work that I'm doing in research. Yeah.
That's great. That's how it's supposed to work, right? Amazing.
Yes, yeah, definitely.
Yeah. I want to stick to, I have a few questions that have come up as you've been talking, but I want to stick to kind of hearing about you and your career first. What do you feel are the most exciting things about your career?
Exciting. Oh, it's a interesting, it's a difficult question in a way. But I think I'd mentioned it. I think the aspect of always being at the forefront of discovery. Sometimes you do things that are are known or they've been tried or tested elsewhere. But the fact that you're doing it in this particular setting, in this specific population, and figuring out how exactly to do it, especially for implementation research, it's all about how did you do it to make it actually work in that particular setting? What measures did you put in place? What strategies did you put in place? So I find that aspect extremely interesting because you're always on a journey of discovery. There's always something new. There's something to that, and it doesn't get monotonous because every every day, everything you do is there's something to challenge you, and there's something new to learn from that particular process. So I do enjoy that particular aspect, and I compare it because sometimes I do see patients, and sometimes it can get monotonous because you're seeing the same patients prescribing the same medication. Maybe the patients come in different ways and with different symptoms, but it's more or less the same kind of presentation, most of the time. But with research, things change. The only thing is that maybe it moves slower, but you're always challenging the way you think, the way you do things, and also meeting very diverse types of people, um, different professionals. So you don't just work with psychiatrists, you don't just see patients, you have almost very different professions from the policy aspects. And in policy, it's not just health, people interested in health. It can be people in the legal justice system, people in the education system, people in the treasury. So you get to have a very wide array of stakeholders that you can engage with and you can learn from. So I find that extremely interesting as well. And then a lot of the studies that we do, it's very it's also multidisciplinary. So you get to understand for example, the work that we've been doing together is about integrating mental health in HIV care spaces. That means then you have to really understand the HIV scene and what is happening in that space. So it's not just sitting somewhere and only doing mental health. You have to understand aspects of that other disease entity and be able to sort of try and speak the same language and learn from each other and collaborate. So it's all new. There's lots of growth. I think I would sum it up as that, and that's what keeps it interesting.
Yeah, great. We here at UW in the space of global mental health talk a lot about the provider shortage globally of specialist mental health providers. And you are a specialist mental health provider working in a context where there is a pretty severe shortage of specialist providers. And I wonder if you could comment on how that's affected the type of work that you do, and just kind of how that colors your experience as a researcher and a clinician, policymaker.
Yeah. Thank you. And that's very true. It has, from the beginning, even for me to decide to do psychiatry in the first place, it was actually the fact that I saw there were very few psychiatrists in the country at that time. And I wondered, why aren't people doing psychiatry? Already in the medical field, there's a bit of stigma around psychiatry. So most people would want to do pediatrics or surgery or something sexier than psychiatry. So, but I thought, maybe because there are fewer people in it, then there'll be more opportunities. And also, who will then be the psychiatrist if we all decide we want to be pediatricians and other people? And yeah, so that was a big part of why I decided to even do psychiatry as a specialization. But getting into the space of research, it's when you say, like, for example, currently we have slightly under maybe 2 psychiatrists for every million people in Kenya, serving per every 1 million population, you have about 2 psychiatrists assigned to that. And that's a lot better than some of these other countries. We feel like Kenya is doing well, you see. But it is a really huge shortage, a really huge deficit when you look at the psychiatry patient ratio. It's, and the treatment gap is also seriously there. So one of the things that this has prompted me to think is, so what really is the psychiatrist role? That really has to be, scrutinized and assessed and really well elaborated, because we're such few psychiatrists in our country and in countries even globally. The psychiatrist role would be more of a supervisory kind of role, whereby you have to you have to be able to train people, a team around you, who can be able to see patients, especially with mild to moderate kind of psychiatry illnesses. And then after that, they'd be able to refer, these people who you've trained, who are under your supervision, can be able to refer persons to you for people who have severe illnesses to you. So that's the only way we can cover more ground. And the people who we train they don't necessarily have to have psychiatry qualification or mental health backgrounds, but they need to be well trained to see the mild to moderate, and they also have to be well, and then you also have to be in a way being able to supervise these people. So for me, a large part of the work that I do, especially for implementation work, is looking at integrating non-specialists in the care provision pathway. And the non-specialists are at various levels. We could have, from the community level, we have community health workers. There's something they can do. It could be screening, for example. It could be very brief, low intensity therapies like PM plus, problem management plus therapy. So then they be able to screen and refer the patients to the facility. Now at the facility, training healthcare workers to be able to actually do an assessment, do a diagnosis, and also manage mild to moderate mental disorders. It's very important that frontline healthcare workers, these are the clinical officers, the medical officers who don't have a specialization in psychiatry, to actually manage is critical. So trying to think through this systems way of thinking, and then at the point whereby at every point you tell them, at this particular level, please refer the patient to the psychiatrist at this particular level. If you see this and this signs, patient is not getting better and things like that, but still having constant supervision. Another aspect that we've also been putting in is through the use of telepsychiatry. So that's also an avenue whereby the psychiatrist may not be present in a particular area, but wherever the psychiatry is, they can be able to be called up on and be able to discuss with the clinician on the ground and see the patient if there's video is enabled, and just be able to discuss, so what can the patient be put on, what's going on with the patient, and things like that. So integrating mental health into primary care spaces is very fundamental to the work that I do. And also using telepsychiatry is also extremely key in being able to bridge this treatment gap that we currently have.
Thank you. So you started talking already about the research that you do, and talked about projects kind of integrated care. I know that you also do a lot of other research in different mental health. So can you tell us a little bit more about some of the research projects that you're working on?
Okay, so Other research, it's also related with integrating care, integrating mental health, is working with healthcare workers themselves. We all know that as much as we want to feel like we are, stronger and tough and all that, healthcare workers are some of the more vulnerable population based on what they're going through, the stress levels, and things like that. So we've put up, we have this particular research work that we work with healthcare workers to manage their stress, and we put in various stress management parameters. It's more like a multi-pronged kind of intervention, whereby we have a mentorship arm in it, we have a leadership arm in it, because they have to keep engaging the supervisors and be able to talk and communicate. But we also have a training on stress management. We use a lot of mindfulness within that particular training to try and teach them about mindfulness, and we do a lot of practice within that. We put them in a WhatsApp group, and we share all these videos, we share resources on how they can keep practicing mindfulness. And every week we share something practical that they can do to keep practicing that. So there's a 2-week training, and then after that we keep following them up, sharing materials, encouraging them to keep well-being, to keep practicing these stress management or well-being practices, and including very basic things like physical activity, like the deep breathing, like nutrition. It seems very simple enough, but those things, at the end of the day, they're the ones which build resilience in each of and every one of us. So we work through that. And this particular research that I'm doing is actually, it's interesting because for now we are focusing on healthcare providers who are in the maternity care spaces. And the reason how we even got into that space is because at that, we were looking at maternal mortality and neonatal mortality, and wondering why are the rates so high, yet people are being trained on all these technical skills of how to handle, let's say, postpartum hemorrhage, for example, how to handle all these difficult situations. People are being trained on them, but still we're having high mortality cases. What's going on? So we did qualitative interviews. We did also a lot of just trying to understand what's happening from the healthcare workers' perspective. And what came out is stress and burnout were a really big issue when it came to managing patients. And sometimes they're feeling stressed, they're feeling overwhelmed, and then they would end up, shouting or treating the mother in a way that is not good. Now, poor person-centered maternity care. And another aspect was an unconscious bias, and biases that healthcare workers generally carry, which are worsened when people are under stress and in a burnout kind of situation. So we actually wrote the grant as a way of reducing maternal and neonatal mortality and morbidity, but targeting stress management and stress management and unconscious bias as the things that we'll immediately tackle. And then let's see, at the end of the day, when we take care of these healthcare workers, do they end up having to treat the patients even better, remembering even what to do when they learn the technical skills? And will we get an improvement in reduction in maternal mortality? Will we get patient person-centered maternity care when we are supporting the healthcare workers themselves? So that's one of the studies that I've been doing and been very passionate about, being a healthcare worker myself. I feel like it really is close to home. I also do a lot of work around genetics. So I know it's a bit far off, but I had a postdoc that I got that was linked with this genetics work. So it's still, we've been looking at genetics, maybe variabilities, especially in people with psychotic disorders. And also now we're looking at postpartum PTSD, post-traumatic stress disorder. And we're trying to see, we have large populations, psychotic disorders are in, the one for genetics of psychotic disorders has been in 5 countries in Africa. So it's large samples. It's really more of just like we collect data on the phenotype, which is, I think, the big part why I'm there. So, and this has also shown me that it's important to have, like the psychiatrist role, even, it's not just about the intervention that you're going to give. When they're running these genetic studies, they really need us to be very, we are called, psychiatrists is called in being able to really say, yes, this person does have that psychotic disorder. So training the research assistants who are going to be using this diagnostic tools is the role I would play there. And also interpreting the data. At the end of the day, you're finding, especially with that aspect of the disorders, the mental disorders and the social demographics, you're finding certain patterns. So as a psychiatrist, you kind of have to be able to discuss that. And then that's probably something that the geneticist will not really know. And even the person who's doing the bioinformatics around it may not really know. So working with a very diverse collaborative team has been quite interesting with this line of genetics of psychiatry. And I feel like that pushes that, the initial urge of why am I doing psychiatry is discovery. A lot of our drugs have just been we happened upon. It's not like we actually tried and got medication that was specifically targeting this particular area or this biomarker. So being able to be at the front of science of that and being able to come up with specific targets, whether it's biomarkers to do with inflammatory markers like cytokines, even cortisol or whatever it is, or it's looking at genetic markers. I think that's a field that would help eventually be able to discover either better ways of screening for these mental disorders and assessing for this, so diagnosis of these mental disorders. And then a second thing is also for medications that are new medications. And we don't have enough. A lot of the genetic data is actually from Caucasian population and maybe Asian populations with very little African data. Maybe when they say African, most of it is Black American or African American. So I got into this space because it gives us an opportunity to, even if they discover a drug or a particular marker for diagnosis, at least our population will actually be there. So that the medication will be meaningful to our people as well. So it's not just that it's been found in this particular race, but maybe it's not been found in this place, or there's something extremely different in our population. So that's another thing. Plus also we have the highest genetic diversity. The Africans have highest genetic diversity. So it does make sense to do a lot of these genetic studies in this population. So I have been in that particular space and I find it interesting because of, that aspect of, getting to maybe discover something at the end of the day or contribute to that discovery in one way or another. Yeah, I think I'll leave it at that.
Yeah, your work is so diverse, and I know there are other projects, like we haven't even talked about your suicide prevention projects. So
yeah.
How you find the hours in the day to do all of these different projects, but it's really incredible. Sorry, did you want to add something else?
No. I thought you were asking how do I find the time to do different
please
projects.
answer. Yeah, that was more of a rhetorical thing, but I would love to hear how you do it.
I work with a team. I think that has been the biggest part of it. I'm not alone. In my department, we have a team. And also the people I collaborate with, I work very closely with different partners, other psychiatrists who are also doing research. So it's been very helpful that I am in that space, very collaborative kind of space, and that allows me to move from one project to another. And I must say, I said from the beginning that for a long time, when I got into KEMRI, it was a very big lobbying process to actually put mental health in the map. And I've been in KEMRI, I think, for the last 12 years. And for that period, we only got another psychiatrist last year. So it's just been one psychiatrist. So one of the challenges I had was being given that position. And then when someone comes and says, we want to do research in this, and people see mental health, they're like, oh, you should talk to that person. So everything, even if they want to they're doing sickle cell study research, and there's a mental health component, so I will be involved in it because there's no other psychiatrist. And I think at the back of my mind, I'm like, but who will do it then if I don't do it? So I haven't super specialized in one area, which is what most people do. Like they become an expert in substance use or only in maybe depression or PTSD. I don't think I have the luxury, and I honestly don't think many psychiatrists in Africa have that luxury to be super specialized. I think we tend to be more broader based on the fact that we're not that many to really super specialize in something. So maybe that has a contributory factor. But I do work with a team that I trust, and I'm not alone. So that's helpful.
I want to go back to you. A couple of times you've mentioned the lobbying effort to get kind of mental health on the map at KEMRI, and I want to talk a bit about that. I think we're seeing, particularly in Kenya, but I think in a lot of places there is increasing interest in recognition of the importance of mental health. And given your role kind of on the research side and the policy side, I would love to hear your insights about how you've seen that shift happen and what does it take to get something on the map, policymakers?
Well, I think the biggest turnaround, especially in Kenya, and maybe globally, was during the COVID pandemic. And during COVID, I mean, mental health was really, in everyone's, everyone was thinking about mental health. And I think a lot of players who are not in the mental health space also saw the importance of ensuring we have enough mental health workers, and that they are also well resourced. So a big shift happened around that time. But just before the pandemic, one of the things that happened was we were put in a national mental health task force, and that came from the president's directive. The president was talking in some national day, and he gave a directive that we have to figure out what's going on in the country. And one of the things that was happening is very, very high rates of alcohol issues, alcohol use disorders, and just substance use disorders in general. So it could be one particular thing that pushes the politician to actually see, no, this is a problem. It needs to be addressed. Who is going to address this? Then now the mental health people or professionals are the ones now who are there. But we as a fraternity have to be extremely ready to take advantage of this sort of, there are bad situations, but there are opportunities as well to take advantage of these kind of opportunities. So when a lot of people, the community members who have been saying, no, our children are perishing under these substance use issues. We need more of mental health workers. We need more attention to this. And then we'd actually use people who are close to the president as the psychiatrist. We'd get people who are close to the president to go and lobby directly and say, indeed, people have been speaking and saying this is a problem. We can find a solution. We can do this. We can do that. We need to fund this. We need to fund that. So being able to be very close to power is helpful, and also using the opportunities that are coming up is also extremely, has been extremely helpful. Right now, there's a whole problem around suicide behavior, suicide deaths in the country. So we are using that to say, you know what, you need to put this and this and these particular measures. We've been talking about this. So we kind of have the ear of the lawmakers, the policy makers, when these kind of emergency situations are happening in the country. And that really helps. The other thing that helped even way back before the alcohol use was the issues around, I think when HIV moved or shifted from it being, just an infectious to a chronic kind of disease. And people realized that you just cannot manage a chronic illness with just ARVs and that's it. These people have a lot of psychological problems that are linked to, it can be directly linked to HIV, but also just the environment and everything. So we managed to get into that space of HIV care and make relevant policies and guidelines within that space. And because HIV was very well funded, then it meant that integrating mental health would also be funded. And there was a lot more push or more resources to fund mental health through the HIV umbrella. So those are some of the ways that we used to try and put mental health in the space. But I think also lobbying from a global perspective has been very helpful. The WHO recognizing the importance of mental health, that it should be at the core of everything. And most countries are signatories to, the UN Convention, and they have to make a lot of decisions. And so because they have to sign and say we are doing this and this and this, so they put aside resources that are especially targeting those areas. So the fact that they're being held accountable at a global level, also at a national level, we can actually push for these changes to happen for the mental health, for mental health to really be taken more seriously. And I think also, we are also a global village because of the digital age. So whatever is happening in the US, whatever is happening in the UK is happening exactly the same, almost nearly the same way in Kenya, for example. We're kind of being exposed to the same exact things. And if maybe in the US, mental health has started, maybe if mental health becomes a big issue, people are really talking about mental health, the same thing would happen in Kenya as well. They would start talking about mental health because we are really just a global village. So that has also helped in creating awareness and pushing the need to invest in mental health interventions in the country. Yeah.
We need to move to the room, but I want to just take another minute to ask you, I think, a question that's on everyone's minds, and it just flows so much from what you're talking about with us being a global village. That this is, I think we all know, an incredibly difficult time in global health, and our globalness has meant that the very difficult things that are happening in the US are also affecting everyone in Kenya. And so I wonder if you could speak a little bit about the impacts that you're seeing of US policy changes in Kenya, and also, to not end on an incredibly disheartening note, I wonder if you could speak a little bit to some of the kind of resilience that you're seeing in the Kenyan health system in this time.
All right, thank you very much. You've rightly put it that it's something that is affecting, the entire world, but I'm sure it's hitting even harder in the US because of the, I think the world for a long time, because of the investments that had been done in the US for, for health, for research, for innovation, it's been a long time, a very long-term investment in staying at the top of innovation, staying at the top of research. So to just have it change suddenly, I mean, it's extremely destabilizing, even for, people of the US. But a lot of these interventions were happening in our countries. So I know there's also a lot of research happening in the US, but also the fact that it's happening, interventions are happening also in our countries, not just the US. Any change there definitely affects us as well. And I think the biggest thing is, especially I've just come from a call, and when researchers are in the middle of, especially intervention studies, whereby you're actually providing care to patients who really need the care and who've entrusted you to continue providing this care, and then you suddenly have to explain that, oh, you won't be providing that care anymore. It's a really, really big deal, because it takes time for you to get to that point with that particular patient. And for a lot of this research, it's actually on a very large scale. It's not just 2 or 3 patients. It's really on a large scale. So the impact is very, very substantial. The way it started out first with USAID funding going down, that was a really big hit because of the funding for our medications. I mean, it was a really, really big hit. And a lot, aside from that, also many people lost their jobs. So that's also a really big deal. But then also for now, what has just happened with the NIH grants, I think the biggest feel for me is, aside from just the job losses, the job cuts, but there's that entrustment the patients had, because you said you're going to be taking care of them for this period of time, you'll provide these services, and there was some sort of contract that went on there. So it's very difficult to come around and say, no, we won't. And in some cases, maybe they wouldn't. Standard of care is a lot less inferior than what you are providing. So you know in your heart, it's almost unethical in a way, because you've already assessed, found the problem, and said this is the solution, and then now you're saying, oh, just go back to standard of care. It's not that easy actually to just shift like that. So I feel like that's a really big blow. Of course, on the grand scheme of things, this innovation takes time to get there. You have to really invest with time. And if you just break that off, coming back again and starting, it's not that easy to just start off from where you left off. Yeah. So I feel like that would be, it would really hit hard, especially the collaborative work we've been doing. I think that's why the European nations, other places, the Asians, we are, a lot more collaboration now is happening in that space. People are looking at grants that are outside the US to do the work. And I think even in those countries, they're looking for researchers from the US who are very good to go to those countries and continue the work. So to some extent, it's really a loss of, the capacity from the US perspective. But right now, I think a way to stay resilient is just looking at other funding opportunities, other partners that you can engage in, that can still continue the work that you're doing, and maybe still interested in working in our own priority areas as well. So that's really the shift that is happening, moving a lot more to looking at other grants elsewhere, and also looking at, just being able to think outside the box. It doesn't have to always be research grants from research, this kind of institutions. It can be philanthropies, it can be, companies who they want to do something in this specific area, or you have to convince them that this is something that you should really be funding. So looking at other funding streams and not just sticking to, the usual ways that we've been doing things, because things have changed. So those are some of the ways we are really trying to stay afloat. But I feel the biggest problem is that, the very strong ties our countries had with the US being sort of shaken significantly. So I don't know how collaborative research is going to continue if this really becomes the case that maybe we don't get sub-awards in our country, in our countries, because if they say we'll just do contracts, then it means we're not on the same, we're not on the same level. Yeah, it feels like maybe there's some country that is more superior than another country. And maybe we're just getting people and participants without that respect of this data also means a lot to us as a country. So being able to maintain that collaborative spirit, I feel like will be very challenging with the current system in the US. Yeah.
Okay, I think we can move to questions from the audience, either in the room or. Yeah.
Linnet, I was really struck by how incredibly like your experience working with policymakers lines up with like best practice for research and best practice for like implementation and policy work. I'm just and I think it feels like there's a unique opportunity in it being a smaller system, and it being like there being fewer experts that like that you're tied in. But I'm curious if you have any recommendations from your experience, you know, for people for US sort of US application of what you learned. Yeah, just if there would be sort of tips that you would give to us to like achieve that level of integration and collaboration between those sectors.
Yeah, I think you're right. Maybe the situations might be different, and but I think the thing that is across the board, and whether it's the US or here, is just being able to speak the language. So you might come from a very research focused space, but you have to package the information in a way that is relevant to them, that makes sense to them. So I think that is really important when you want to bring in policymakers or even other players. Try and think of that audience that you're giving. Maybe what is it that they are mostly interested in? What do they care most about when it comes to the work that you're doing? What is it that they really they care about? And so you package the information that you're sharing in a manner that they would be able to first understand it and even care about it more. Yeah, and that in itself, and keep bringing them on board, even in your own meetings. Invite policymakers to your meeting. Let them know what is happening in the landscape and how it matters to them, and things like that. There are times when we've had to even talk with people from Treasury because they're the ones who have the budgets, for the country. But when we talk, we have to package it and like, what does it mean to put in $1 to treat depression? How in Kenya shillings to treat depression here and there? So being able to package it in a way that makes sense, I think, is extremely critical. And being able to involve them, bring them on board, find also a champion among them. They are usually people who care about mental health or whichever field you're doing your research in. Find who is interested, maybe from their personal stories, and then bring that person on board, explain to them, and they'll be able to explain it to the other counterparts and make it make sense to the other counterparts. I hope that's useful.
Yeah, that's tremendously useful. And I think it's just exciting to hear somebody that's been so successful in this, because I think this is something that a lot of people have ambition to do well, and it feels like you're really doing it. Like, I love that you're talking about inviting policymakers to your meetings. Yeah, it just, and that the most important thing is to speak the language. And it makes me think that you're being more of a generalist and less of a specialist may actually really help with that as well, because you're
Sure.
all, you're staying neurally very like flexible because you're not delving into something so deeply that that's the only language you speak. So yeah, I'm excited by like just how much your practice form is an incredible model for what sort of best practice of what we can do in this realm. Thank you so much.
Thank you. Thank you.
Do we have any more questions online or in the room? Yeah, we have one here.
Thank you so much, Lynette. I was just wondering, as somebody who's more of a mental health care provider in the formal mental health sector, have you had any opportunities to collaborate with more spiritual and traditional healers? And do you see this as a potential beneficial model for mental health care?
Wow. Okay, that's a really great question, and maybe that's what I didn't talk about. My latest project is actually not so much research focused. It's a policy kind of a project that is focused around policies more, and I'm actually working with religious leaders and in terms of suicide prevention. So when I was doing a lot of my PhD work around suicide prevention or looking at suicide epidemiology, we did a lot of interviews, and religious leaders were saying actually a lot of the people come to us with suicidality and with suicidal behaviors, and because the suicide is deemed more of a spiritual issue more than a health issue in our setting. And another thing, there's so much taboo around it. So they would go to a religious leader to be prayed for rather than even go to a psychiatrist or a psychologist to be taken care of. So I saw that's a really important gap. And so what we did, we did qualitative interviews, so FGDs with religious leaders, trying to understand barriers and facilitators to, being able to provide crisis support, and also being able to do suicide prevention advocacy kind of work, creating awareness, reducing the stigma around suicide. And after the exploratory work with the FGDs, we also talked to people with lived experiences. We also talked to mental health workers about how would it work. We want to do a manual, a training manual. How would this? Should we include here? So we did that. We had a co-development workshop of coming up with a manual, a suicide prevention manual. And what we focused on initially was on how do they provide that suicide crisis support. Someone has just walked in to the room and says they're having suicidal thoughts. How do they support that person? So we went through all that. We've developed a manual that now targets. It has that as a module on how to support and refer. It also has, how do you talk about suicide? What was this whole decriminalization of suicide in our country all about that happened recently? Why should suicide be looked at as a health issue and not really just too much of a spiritual or like something, wrong as such, more of a health issue that needs to be addressed, more than a moral issue. And we also put in even post-intervention care. How do religious leaders handle burials, for example, because the burials are very stigmatized in our country and most of Africa if someone died of suicide. So how do they conduct a ceremony? There's that post-intervention care. How do they take care of the loved ones who've been left behind? And also self-care. How do they take care of themselves as well? So we've developed a whole training manual, that did a pilot. We've just completed that work. So I'm very excited about working with non-professionals, especially when you see that they have the reach, they have the influence, and they can be the ones who actually do the first care, but refer patients to the normal, healthcare systems. I think it's really important to identify who these gatekeepers are, and be able to train them, but make it more meaningful to them, work with them to develop the material so that it's owned by them at the end of the day. Yeah. I hope that was useful. That's helpful.
Thank you. Thank you.
We are at time. Thank you so much. This has been an incredible session, Linnet, and really makes me think just how incredibly useful the model of everything you're doing. I don't know. I'm just really inspired by everything I've heard, and feel like I want to share this recording widely with many people that I've been working with as a way of just spurring our work and inspiring our work even more. Just tremendously excited about what you shared. So thank you so much for making time for us this morning, and we'll be in touch.
Yeah, thank you, Linnet.
All right. Thank you. Thank you. Thank you so much for inviting me. Thank you, Keshet. This has been really great for me as well. Thank you so much.
That's a question that I will try to send you an email because it came just at the end.
Okay, that's okay. I'll be happy to answer that. Thank you.
Thank you.
All right.
Thanks.
Thank you. Thanks, Keshet. Have a good day.
Bye.
Bye.
You're great. She's great. She's amazing.